tumor of the CNS may originate in the brain or spinal cord. If it is originated from brain or spinal cord, then it is called primary tumors. Or may spread to the brain from another primary site of cancer, it is called metastatic tumors. Primary CNS tumors are the second commonest. Primary CNS tumor are the second commonest form of cancer in infant and children under the age of 15 years, exceeded in frequency only by leukemia. Both benign and malignant CNS tumors are capable of producing neurologic impairment depending upon their site. Now the classification of CNS tumors. First one is gliomas. What are the types of gliomas? Adult type diffuse gliomas, astrocytoma, oligodendroglioma, glioblastoma. Then pediatric type diffuse low-grade gliomas, diffuse astrocytoma, angiocentric glioma. Pediatric type diffuse high-grade gliomas, diffuse midline glioma, diffuse hemispheric glioma, then circumscribed astrocytic gliomas, pilocytic astrocytoma, subependymal giant cell astrocytoma, and choroid glioma. Then glioneural and neuronal tumors, ganglioglioma, ependymal tumors, supratentorial ependymoma, ZFTA fusion positive. Then choroid plexus tumors, choroid plexus papilloma, choroid plexus carcinoma. Then embryonal tumors, megaloblastoma. There are different types of megaloblastoma, WNT activated, SMCH activated, and TP53 wild type and TP53 mutant. Then pineal tumors, pineocytoma, pineoblastoma. Cranial and paraspinal nerve tumors, schwannoma, neurofibroma. Meningioma, hematolymphoid tumors, lymphoma, CNS lymphoma. Among the primary brain tumors, glioma constitute 50 to 60%, meningioma 25%, schwannoma 10%. Now the most important tumors, gliomas. The term glioma is used for all tumor arising from neuroglia or more precisely from neuroectodermal epithelial tissue. Gliomas are the most common primary CNS tumor. They include tumor arising from astrocyte, from oligodendrocyte, from ependyma, from choroid plexus. Gliomas, the most common group of primary brain tumors, include astrocytoma, oligodendroglioma, and ependymoma. However, as is true of many hematologic malignancy, it appears that this tumor derives from multipotent progenitor cell that preferentially differentiate down a particular cellular lineage. Now, astrocytoma, including Glioblastoma multiforme. The two major categories of astrocytic tumors are diffusely infiltrating astrocytoma, WHO grade 2 to 4, and more localized astrocytoma, most common example of which is Pilocytic Astrocytoma, WHO grade 1. So WHO grade 1 is Pilocytic Astrocytoma. Astrocytomas are the most common type of gliomas. In general, they are found in the late middle life with a peaking cis-decade of life. They occur predominantly in the cerebral hemispheres and occasionally in the spinal cord. Astrocytoma have tendency to progress from low grade to high grade of anaplasia. Low grade astrocytoma evolves slowly over several years, whereas higher grade bring about rapid clinical acceleration of the patient. higher grade, which are higher grade, Anaplastic astrocytoma and Glioblastoma multiforme. These two are high-grade tumors. The diagnosis of various types of astrocytoma can be generally made by looking H&E morphology, immunohistochemical staining with glial fibrillary protein GFAP, or by electron microscopic demonstration of glial filaments can be done. Mitotic activity of astrocytoma can be assessed by proliferation marker Ki67 and PCNA. At molecular genetic level, low-grade astrocytoma overexpress platelet-derived growth factor A, PTGF-A, and mutation of p53, while high-grade astrocytoma show mutation of two tumor suppressor gene, RB gene and p16. Morphologic features. Astrocytoma have been conventionally divided into three progressive histology grades. One is fibrillary, then gemistocytic, and protoplasmic. Among these, fibrillary is the most common. However, currently WHO classification of astrocytoma is widely used, which divide them into four grades from grade 1 to grade 4. Grade 4 is Glioblastoma Multiforme. Now, pathogenesis. Glioblastoma tends to occur in two different clinical settings, most commonly as a new onset disease, typically in older individuals, and less frequently in younger patients due to progression of lower grade astrocytoma. Secondary glioblastoma, as their lower grade precursor, are associated with driver mutation of IDH1 or its homolog IDH2. Morphology. Microscopically, these tumors are hypercellular compared to normal, white matter and features enlarged, elongated or irregular hyperchromatic nuclei embedded within a fibrillar background that is often GFAP immunoreactive. Anaplastic astrocytoma have a similar appearance but are more densely cellular and have readily detectable mitotic activity. In glioblastoma, variations in the appearance of the tumor from region to region is characteristic. Some areas are firm and grey-white, while others are soft and yellow due to necrosis or red due to hemorrhagic and hypervascularity. The histologic appearance is similar to anaplastic astrocytoma with the additional features of necrosis and the microvascular proliferation. Necrosis in glioblastoma often occurs in a serpentine pattern with tumor hypercellularity along the edges of the necrotic regions, and histologic pattern referred to Pilocytic pattern. So this is the gross image of diffuse astrocytoma. This is the gross appearance of Glioblastoma multiforme. This is the necrotic area. This is the tumor mass. Hemorrhagic necrotic portion. And this is the microscopical picture of glioblastoma. This is the necrosis, necrosed part. These are the necrosed part. So high-grade astrocytoma have abnormal vessels that are leaky with an abnormally permeable blood-brain barrier and therefore demonstrate contrast enhancement, which is often ring-like in glioblastomas. The prognosis for individuals with IDH wild-type glioblastoma is very poor. So the prognosis is very poor in glioblastoma multiforme, which is WHO grade 4. Although the use of newer chemotherapeutic agents has provided some benefit. Oligodendroglioma, the other major subtypes of infiltrating glioma, is comprised of cells that resemble oligodendrocytes. When corrected for tumor grade, the oligodendroglioma have the best prognosis among glial tumor. As with their astrocytic counterpart, they are now defined using morphologic and genetic features. This tumor constitutes 5 to 15% of glioma and are most common in the 4th and 5th decade. Patients may have had several years of neurologic complaints often including seizures. Now the pathogenesis. Oligodendroglioma is molecularly defined by an IDH mutation in combination with whole arm chromosomal co-deletion of 1p and 19q. Additional genetic alterations occur with progression to anaplastic oligodendroglioma. The more common of these include loss of chromosome 9p, which results in deletion of the CD8 tumor suppressor gene. Now the morphology. Oligodendrogliomas are gelatinous gray masses often with cyst, focal hemorrhage, and calcification. The tumor composed of sheets of regular cells with spherical nuclei containing finely granular chromatin, surrounded by a clear halo of vacuolated cytoplasm. The tumor typically contains a delicate network of anastomosing capillaries resembling chicken wire. Now, anaplastic oligodendroglioma, it is WHO grade 3. Are characterized by a higher cell density, nuclear anaplasia, increased mitotic activity, and occasionally necrosis. Pilocytic Astrocytoma is WHO grade 1. Are distinguished from infiltrative astrocytoma by their more discrete border, unique histopathology, molecular characteristic, and relatively benign behavior. So pilocytic astrocytoma is WHO grade 1, means it is low grade. It is low grade tumor. Now the morphology. Pilocytic astrocytoma is often radiologically and grossly well demarcated and cystic with a contrast-enhancing mural nodule. Histologically, it differs from infiltrative astrocytoma of any grade by showing only limited brain invasion, with an often biphasic architecture combining loose microcystic and compact densely fibrillar areas. The tumor is composed of bipolar cells with long, thin hair-like process that are GFAP positive, form a dense fibrillar meshwork, Rosenthal fibers, and eosinophilic granular bodies. This is the microscopical picture of pilocytic astrocytoma. Then ependymoma. Ependymoma are tumors that most often arise in proximity to the ependyma-like ventricular system, including the obliquetic central canal of the spinal cord. In adults, the spinal cord is the most common location. Tumors in this site are more frequent in the setting of neurofibromatosis type 2, NF2. Now the pathogenesis of ependymoma. Given the association of spinal ependymoma with NF2, it is not surprising that NF2 gene on chromosome 22 is commonly mutated in ependymoma arising in the spinal cord but not at other sites. Ependymoma do not share the genetic alterations that are found in infiltrating gliomas. Morphology. Grossly and on MRI, ependymomas are solid mass that is non-infiltrative. It is not infiltrative. In the posterior fossa, they typically arise from the floor of the fourth ventricle, occasionally growing through the foramina of Magendie or Lusca and extending below the foramen magnum into the cervical spinal canal. Ependymoma are composed of cells with fibrillary process that contain regular round to oval nuclei with granular chromatin. Tumor cells may form gland-like round or elongated structures that resemble embryologic ependymal canal with long, delicate process extending into a lumen more frequently presenting perivascular pseudo rosette. It is the gross image of ependymoma, tumor in the fourth ventricle. This is the mass, tumor mass, ependymoma. So this is the microscopic pictures of ependymoma. These are called rosette and perivascular pseudorosette. These are pseudorosette. If these are the true rosette and these are the pseudorosette. Now embryonal neoplasms. A large category of mostly pediatric tumors is described as embryonal, meaning that they appear primitive or undifferentiated, although a limited degree of neuronal and less commonly glial differentiation is often encountered. The most common embryonal neoplasm is the megaloblastoma, which accounts for 20% of pediatric brain tumors. Now the megaloblastoma. Molecular subtypes of megaloblastoma have been identified through genomic studies, revealing alterations of signaling pathway involved in normal cerebral development, such as SMCH pathway or sonic hedgehog patched pathway, which is involved in control of normal proliferation of cerebral granule cells, and the WNT beta-adenine signaling pathway. These are the two pathways involved in the pathogenesis of megaloblastoma. One is SMCH pathway, sonic hedgehog patched pathway, and WNT beta-adenine signaling pathway. Now the morphology of megaloblastoma. Megaloblastoma is often well circumscribed, grey and friable, and may extend to the surface of the cerebellar folia and involving the leptomeninges. On microscopic examination, the tumor is very densely cellular, with small primitive appearing cells. Individual tumor cells have scant cytoplasm and hyperchromatic nuclei that are frequently elongated or crescent shaped. Mitosis are abundant, and markers of cellular proliferation, such as Ki67, are positive in a high percentage of cells. In the classic subtype, tumor cells form Homer-like rosette and often express neuronal markers such as synaptophysin. This is the gross image of megaloblastoma, replacing the part of superior cerebellar vermis. So this is the microscopic appearance of classic megaloblastoma. These are the small blue cells. You can see here lots of small blue cells. And these are the Homer-like rosette. These are the Homer-like rosette. You can see here large cells, variant, increased features, increased cell size, large nucleoli. These are the nucleoli. Now meningioma. Meningiomas are predominantly benign tumors of adults that arise from the meningothelial cells of the arachnoid and are usually attached to dura. Pathogenesis. The most common cytogenetic abnormality is loss of chromosome 22, especially the lower arm. The deletion includes the region of 22q12 that harbors an F2 gene, which encodes the protein myelin. As expected, meningiomas are a common lesion in the setting of NF2. Now the morphology. Meningiomas are usually rubbery, rounded, vacillated dural mass that compress underlying brain but are easily separated from it. They may also grow in plaque, in which the tumor spread in a sheet-like fashion. Along the surface of the dura, this form is commonly associated with hyperostotic changes in the adjacent bone. The lesion range from firm to finely gritty, the latter typically due to numerous pseudomorphous calcification. This calcification is known as pseudomorphous calcification. Many histologic patterns are observed, with most showing no prognostic significance. The most common include meningothelial, containing clusters of epithelioid cells with fuzzy and indiscernible cell membranes. Pseudomonas with predominance of pseudoma bodies, the latter representing concentric rings of calcification deposited over pre-existing holes. Anaplastic meningioma, that is WHO grade 3, is a highly aggressive malignancy. They account for 1 to 3% of all meningioma and may arise de novo or from malignant progression of lower grade meningioma. This is the meningioma, gross image of meningioma. And this is the microscopical picture of meningioma. You can see these are the calcification. Calcification with concentric rings. This is the picture of meningioma.